Today's talk is on spontaneous intracranial hypotension. I thought this would be a great talk, especially for this venue, is with neurology, hopefully joining online, because the neurologists are obviously very involved, a critical part of this team on the front lines of headache evaluation. This is a super hot topic for us. Today, my goals are going to be that you will be able to recognize the intracranial imaging manifestations and mimics, importantly, and understand the classification system for the different types of spinal fluid leaks and how that dictates the workup. Along the way, I'm going to be showing you new techniques that we've made in improving diagnosis, which has changed a lot in the world of leaks, spinal leaks. So if you just plug in spontaneous intracranial hypotension, you see like an exponential increase in number of articles. In our AJNR along last year, there was 16. Last month, journal had 5 articles. So this is a super hot topic for neuroradiology. Let's talk about what spontaneous intracranial hypotension is. It's a neurologic syndrome which can present with absolutely debilitating headaches that are almost always at some point orthostatic. What is it caused by? It's caused by a spontaneous CSF leak. So obviously, if it's a post-LP, we don't call that SIH. The vast majority occur in the spine. That's extremely important. So you're not going to be ordering CT cysternograms if you have a patient with SIH or suspected SIH. If you have a patient with rhinorrhea, you have, because of idiopathic intracranial hypertension, or you have a patient with otorrhea who's had a skull base fracture, they're not going to develop the intracranial manifestations that I'm going to show you. They're not going to develop orthostatic type headaches. The prevalence of this condition is thought to be 4 to 5 per 100,000. For reference, subarachnoid hemorrhage is around 8. So, wow, how do we know that? We don't know that. That number is probably really low. There's probably a lot of people walking around with headaches that don't get diagnosed. The mean age, 40 years. So this is not a diagnosis made typically in the pediatric nor the geriatric age groups. It's middle-aged. Patients that end up having leaks caused by CSF venous fistulas are about a decade older. They're in the 50s, late 50s. There's always been a female predominance. If you have someone with SIH, you want to at least think about, do they have Ehlers-Danlos or Marfan syndrome? There is that connection. But that would be rare, obviously.
What's the connection? Is it the dura is thinner or more?
The dura is thin and friable, exactly. You would also consider looking for aortic root dilatation, and there's an association with intracranial aneurysms. There's also associations with nerve root sleeve diverticulum, thinking that they're more easily damaged, and there's tears around the diverticulum. And then obviously with osteophytes and degenerative spine causing puncture of the dura. The pathophysiology is very interesting. So we're calling this spontaneous intracranial hypotension, but most patients have a normal opening pressure or even high. So you cannot exclude the diagnosis. You can make the diagnosis if the opening pressure is low, but you can't exclude it if it's normal. So we'd like to think that we should rebrand this as CSF hypovolemia rather than hypotension. And as such, a lot of the intracranial manifestations I'm going to show you are explained by the Monroe-Kelly doctrine. One of the neurosurgery residents could briefly state what the Monroe-Kelly doctrine is.
Go ahead.
Basically, there's a fixed space in the skull. So it's made up of brain, blood volume, CSF.
Right. And so if you start draining a large amount of CSF out through the lumbar spine, increase the capacitance of the lower lumbar spine fecal sac, because decrease the filling pressure, you're going to move the point of hydrostatic indifference point caudally, and that's going to significantly drop intracranial pressure, especially when you stand. And a lot of the things I'm going to show you, not all, are explained by venous hyperemia, engorgement of the veins, because they're most compliant. They're the thing that can respond the quickest to a loss of volume. So you're absolutely right. Good. Clinical presentation, orthostatic headache is the hallmark symptom, and this is reported by 85% of people who end up having a leak. Well, that means 15% wouldn't say they had orthostatic headaches. So you can't use it to say that they don't, it's not required for the diagnosis, but it is a hallmark. Interestingly, it's the most common symptom to wane over time. So if you see a patient that has stigmata intracranially of a leak, but they say their headaches aren't orthostatic, go back in time with them. What was the nature of your headache when it first started? Because almost always it will be orthostatic at one point. Interestingly, you see associated symptoms, a lot of audiovestibular manifestations, cognitive impairment, so-called brain fog. And then we see some rare presentations, which are fascinating: frontotemporal dementia, brain sag syndrome, bibrachial amyotrophy, which is where patients misdiagnosed as having ALS, who ended up having this syndrome. Superficial siderosis, if you see hemosiderin layering, especially in the posterior fossa, this is the most likely cause, is that there's a spinal leak somewhere. And of course, patients can present even in a coma. So let's look deeply now at the culprits, spinal CSF leaks. All of the images I'm going to be showing you on the right are from Dr. Shivik's paper from Cedars-Sinai in the New England Journal in 2021. This is an excellent review. Type 1 is a dural tear, and you can see this like blade-like or knife-like osteophyte puncturing through the dura and causing spill of CSF into the epidural space. This is what we call SLEC positive, spinal longitudinal extradural collection positive. These will almost always have it either on MRI or CT myelogram will have a collection outside the thecal sac. Type 1A, the puncture is ventral. Type 1B, the puncture is dorsolateral. Type 2 is the meningeal cyst. And we might see lateral CSF collections, and they're often associated with the meningeal diverticulum. So what is thought to happen is that in even mild trauma, that these patients maybe like, oftentimes I see this in like golfers. I've seen 2 golfers now who developed this, that felt a pop in their back, and then they developed a leak associated with the nerve root axilla where there was a meningeal diverticulum. This particular type of leak, the presence of an epidural fluid collection is variable. It depends on where the tear is out the nerve root, whether you're going to get that or not. The type 2B, it would be with like dural ectasia, where the dural is friable, like in ankylosing spondylitis. Type 3 is the hardest one for us to be able to diagnose. It's very hard because we need high, not only spatial, but temporal resolution imaging. This was only described in 2014, not because it didn't exist before, but because we couldn't show it. So it was suspected. When there was no evidence of contrast leaking outside of the sac, but the patient would have profound orthostatic headaches and have positive brain MRI findings. This was the proposed mechanism. And what we can see now is that there is a meningeal diverticulum, contrast is leaking out of it and quickly being taken away by a vein because of the fistula. So you can see why you don't build up any contrast there, despite this shunting.
Can you talk with Rick? Is contrast put in the CSF and it fills the nerve sleeve?
Yes.
So is this a serial scan like an arteriogram? You're seeing the flow. Is that how you have to do it?
The main secret is it must be decubitus. The myelogram.
Okay. But the dye settles in the CSF over there in the nerve root.
Correct.
And then you watch the dye slowly flow. So you have to do serial imaging like an arteriogram.
Yes, there's 2 options. This is digital subtraction myelogram, exactly, where the patient's tilted up and the contrast is injected and serial images are taken. Okay. That's correct. That's DSM. Another way to do it, I'll talk about later, is with CT. We can do it with CT as well. Yeah. And CT myelogram has been, in some studies, shown to have increased diagnostic capacity over DSM, although Cedars-Sinai exclusively does DSM. So, all right, one other thing I wanted to point out, the type 1 dural tear siderosis risk is the highest. And the type 2 and 3, type 2, it's variable. Type 3, we've never seen siderosis develop. And then the other thing important to say is that even though we thought CSF venous fistulas were rare, now we're realizing that they might be the most common. Dr. Shivink went into a great deal of detail in this article recently in the AJNR. If you see contrast out laterally, he describes what he's found surgically. And as I said before, he's found tears at the shoulder and in the axilla of the nerve root. And this is responsible for lateral CSF leaks. And again, you'd want to do this myelogram decubitus if you thought that the CSF leak was lateral because of where you saw it on MRI imaging. This is a nice example where this is a cone beam CT. So this is a decubitus myelogram, DSM, right? And you see the contrast filling, you're like, what's going on here? They use something called cone beam CT, which is a technique that is available with some angio suites. I don't know if you have that or not. It's not widely available. The downside of it is only covers up to about 6 levels. So you have to know where you're looking. It's not like CT that you can cover the entire spine. But look at the resolution. We see now that this is not a Tarlov cyst. This is not a perineural cyst. This is a tear of the dura in the nerve root axilla, and CSF is spilling out. And it took the cone beam CT to actually see that there's extradural CSF spilling out. It's actually a leak. This is another nice example of a lateral dural tear from Duke. And you can see that there's a tear in the dura and the arachnoid is now billowing out. So that you could possibly mistake this for a nerve root sleeve diverticulum, but in fact, it's the primary problem is the hole in the dura. All right, let's talk about cranial manifestations. Extremely important that you recognize these. The mnemonic is really nice. It seeps, subdural effusions, enhancement of the pachymeninges and large veins, pituitary enlargement, and a sagging brain. Importantly, up to 20% of patients may have a normal brain and an active leak. So they have compensated or the leak's not great enough or something. So a normal brain MR does not exclude it. It just really lowers your probability. So let's talk about the dural enhancement. That's extremely important. This is our most sensitive specific finding on a MRI with contrast. Look at the dural enhancement as if I took a fine point Sharpie and outlined the dura, right? It's not nodular, it's not mass-like, because then I would start to think about leptomeningeal metastatic disease. It does not go over the peel surface. It is not leptomeningeal enhancement, it is dural enhancement. Very, very important. Why? Because of the venous engorgement. Because we believe that
dural veins?
Yes.
Dural veins.
We believe of the dural veins, yes.
In the dura.
Yes.
So the dura would actually thicken like a edematous
Yes.
dura?
Correct. And you could get, and then you can see in this patient, it's not quite so obvious, but do you see there's a small subdural effusion as well?
It's interesting. I know it.
So the other finding, which you won't be surprised to hear about, is the venous distension sign described in 2007. Sometime on the sagittal MRIs, it's kind of hard to tell midline whether is this a large vein, is it pathologic or not. The venous distension sign was defined as going halfway out in the dominant transverse sinus and looking at the morphology of the sinus. Normally, these are low pressure veins and they're concave. The margins are concave. So if you look at the inferior surface of the transverse sinus, it should be concave, maybe flat, but not convex. If you look at an axial CT scan, you're familiar with looking at the sagittal sinus posteriorly as a delta, right? If it rounds up like a ball, that's not normal. That's venous distension. All right, prominent pituitary gland. This is kind of fascinating. A lot of times I think we miss this because it's young females and we go, oh, maybe that's just normal, that the pituitary is somewhat prominent. They get the fistula fixed and the pituitary becomes small. And we go, oh, gee, I guess that was a positive finding. Yes, these people can have elevated prolactin levels, and there have even been case reports of patients presenting with galactorrhea. So you can see how that could possibly mess you up. Notice, however, that not only do I have a prominent pituitary, but I have diffuse dural enhancement. That's where the money is. You want to be looking for that finding. It can go away over time. Another thing I should say, a lot of radiologists don't pick this up, and I'm not sure why out in private practice. I've seen this several times before, just not picked up as positive. So you want to get the patient's history early. When the headache started, were they orthostatic? get the prior imaging, almost certainly they have it. Did they give gadolinium? Look at it yourself. Is there dural enhancement? Because that can help make the diagnosis. And now probably one of the most important points. Remember, CSF's leaking out, the brain is being sucked down through the foramen magnum. We're gonna look for findings now that mean the brain is sagging. Look at where the floor of the third ventricle is relative to the dorsum sella. And I've included a normal here for you, floor of the third, dorsum sella. So you see that we've lost our suprasellar cistern. We've lost it in this case. The chiasms drape over the dorsum sella. Because of this midbrain descent, the distance between the mammillary bodies and the pons has decreased. The pontomesencephalic angle has become acute. And the amount of CSF in the prepontine cistern has dramatically decreased. Despite all of this mass effect looking imaging, we have really prominent veins, right? So it's not just mass effect, but it's the veins are enlarging because the brain is slumping. In terrible cases, I've seen one, there was a patient in the ICU in a coma. They didn't know what was wrong with him. And he had midbrain compression, cranial nerve findings. The history had long since been lost that he had orthostatic headaches at one point, right? And a neurosurgeon actually even got talked into biopsying this enhancing dura. So you just be aware that this is can be a real fuller, okay? We've developed something called the Bern score, which it was Bern, Switzerland is where the article came out. And it's a probabilistic score that tells you how likely are you to find a leak on myelogram. Okay, so that's kind of nice, right? It's not yes or no, but it's how likely are you to find a leak. The major criteria are things we've seen: pachymeningeal enhancement, no surprise. Engorgement of the venous sinuses, suprasellar cistern less than 4 millimeters. Those are each get 2 points apiece. Minor criteria, subdural fluid, that's not that common. Prepontine cistern decreased, mammalopontine distance 6.5 millimeters or less. If you have a score greater than or equal to 5, that's high probability. But notice in the 0 to 2s, they still had like 6.6% people had leaks. So you could still have a low probability score and have a leak. Also, the Bern score was only designed to look for type 1 and 2 leaks, the SLEC positive leaks, the fast flow leaks. It was not designed to look for fistulas. They didn't do decubitus myelograms that you need to do to look for fistulas. Fortunately, this year, a paper came out that did exactly that. And it also found the fistulas were only in the high Bern scores and not in the low. Although all the papers say, we've seen it before, but we've seen it before. So don't think that you can have a negative brain MRI completely excludes this. So let's look at a lesser known cranial imaging finding, which I think is fascinating. This is what's called Lair cranial hyperostosis. This is a normal skull. And here is a skull where you actually see it looks like 2 skulls, doesn't it? On the MRI, it looks like there are 2 skulls. So what has happened with prolonged decreased intracranial pressure, the skull is actually getting thicker but because of layered appositional bone formation. Not terribly sensitive, no surprise there, but pretty specific if you do see it. And I think I used to see things like this in children that had been over shunted. Their skulls would become thicker. So it's kind of interesting. I like this title, the Monroe-Kelly Doctrine, a review and call for revision, because you said the calvarium was rigid, and they're just trying to point out, that the calvarium can also respond. But I think like when Dr. Cushing talked about these elements, the Monroe-Kelly Doctrine in the 20s, he was saying these things happen rapidly. Well, this is not going to happen rapidly. It's not a rapid compensation. So let's talk about imaging mimics and pitfalls, extremely important. Dr. Dillon loves to show this case because he likes to say, oh, look at the descent of the floor of the third ventricle. Look at effacement of the suprasellar cistern. Mammalopontine distance, nothing. The mesencephalic, pontomesencephalic angle, 0. Prepontine cistern, 0. All the findings I just showed you of the sagging brain, right? But this patient has hydrocephalus and has cryptococcal meningitis. So he's herniating. So this is the problem that I don't want to have anybody make that mistake. It's just because you start to make measurements of the suprasellar cistern, measurements of, the pontomesencephalic angle. I don't want you to think that you can measure something and ignore the constellation of the clinical history and all of the findings on the study. Yes, this patient has dural enhancement, but he also has leptomeningeal enhancement. So this is, meningitis. Another example, this is from my cases of colloid cyst, third ventricular colloid cyst. On the flare, we see transependymal flow of CSF. And again, pontomesencephalic angle is acute. Well, I hope you're not going to measure that and say this is SIH. No, it's because the patient has hydrocephalus and there's descent of the brain because of that. Here's the biggest pitfall of all. And if there's nothing else that you walk away with concerned about, this should be it. And that's PRE1. PRE1, as you know, is descent of the tonsils greater than 5 millimeters below foramen magnum. Oftentimes there's a flattened skull base. Oftentimes, in the majority of people, the posterior fossa dimensions are small. Look at the midbrain. Look at the distance between the mammillary bodies and the pons. Look at preservation of the suprasellar cistern, okay? Now, here's our friend with SIH. Yes, these tonsils are low, that is true, but the midbrain has descended, okay? So that's a really, really, really important difference. Plus, look at the intracranial veins, and this patient even has the double skull sign, so he's had low pressure for some period of time. This is a great article in JAMA. Imagine you were sent this patient for posterior decompression. Here you've got a Chiari malformation. You've got a syrinx even. Wow, right? And if you got the prior films, you would see that he developed this. We don't develop a Chiari malformation. If anything, the tonsils ascend and you get more room around your posterior fossa with time, not less. So that would be concerning. Hopefully you would see that some crowding of the midbrain, but at the very least now after today, you're going to get a brain MRI with contrast and you're going to look for all the findings of CSF hypotension before making the diagnosis of a Chiari-1. I went to look for a nice example of a Chiari-1 and I went onto this RAD source. It's a nice teaching files. So I'm like, okay, yeah, there's tonsillar ectopia, but there's also descent of the third ventricle floor. The pituitary is prominent. I can't use that. So, and this is online. So this is not easy. This is not easy. This is something that could really mess you up. So next, this is Shivani's ER case. This was a male recently assaulted, and she got called to the ER to look at this guy. And the imaging findings are, wow, this is a tight brain, cisternal effacement. There's a collection, subdural collection. There's some midline shift, some compression of the lateral ventricle. It's tight. And then I see this abnormal finding. What is this? Why is the collection subdurally not the same density as this? If this was just another subdural, that would be kind of weird. So maybe it's the venous sinus. So anyway, so Shivani, what did you find when you went in and looked at it? What did they tell you?
Yeah, so he was 31, and like you said, recently assaulted, and I think me and the attending had seen the films and were very concerned going down to see this patient, but I was a junior resident. When we came into the room, he would be on his cell phone and wide awake if he was laying flat, completely normal on his cell phone, like texting. And then if you sat him up, he would start to become obtunded.
Yeah, I hate to laugh at that. It's not funny, but yeah, it's like, wow, what is it? Yeah, right? So one thing I could say about the imaging is that you do pick up the fact that this is a another subdural collection. Why is it acute and that not? I mean, what's going on? So sometimes you can just do the simple thing of looking at their little reformations that they always make, right? The sagittal and coronals, and it helps you to understand what something is. So this was just a huge sagittal sinus. When we look at the transverse sinuses, we see that they're ballooned out. So the good news is the next study I'm going to show you is an MRI with no craniotomy having been performed, which probably make things a lot worse, right? So the classic findings, diffuse dural enhancement. This particular case, he's got subdural effusion, but only on one side. He's obviously got, you know, the midbrain slump, and he's got prominent sagittal sinus and a prominent pituitary. So he's got everything. He got a blood patch.
Yeah.
That was his treatment. So, you know,
No diagnosis.
he had some imaging, and there was a suggestion that he had some pitting at the skull base. So you go, well, what does that have to do with it? Well, there's a suggestion then that he had idiopathic intracranial hypertension that might have sprung a leak with one of the CSF venous fistulas from a diverticulum. That's going to take a lot of work to fix that. And a patient like this, you do a blood patch. You don't like, you know, try to do this huge diagnostic workup in somebody who's obtunded. Just do a blood patch, because even no matter what the cause of the leak, there's a strong chance that that's going to help them. So it might not be durable, may not last, but at least, you know, I mean, your other option, if this person's completely obtunded, is there's, I think UCSF has shown putting a catheter in the fecal sac and infusing saline.
So how do you relate the trauma to this? Because this guy presumably was asymptomatic, and did the trauma exactly knock off a hole in his dura to let his dura start leaking into whatever?
I think it was incidental.
or did he-
I think it was incidental.
It's what created a lot of clinical confusion, because we saw a scan with what we thought was cerebral edema in an recently assaulted patient.
So in theory, practically, he probably had this leak fistula
Right.
already, but it wasn't
Right.
big enough.
Right.
But it raises the question about trauma being potentially some contributor to the formation of it. At some point, it may have been trivial trauma or whatever. So, but you never found out where it was leaking from. And it also raises the question about when is blood patching likely to help? You see it early before symptom new onset, more likely to help than in the chronic stages.
Yes.
How you put that together?
Yes, that's been studied. Yes, yes, blood patches, large volume better than small volume. Targeted, the studies that target, I'm just gonna go through this later on, but yeah, you want me to just, I'll just continue, but I'm gonna answer all of that.
Okay.
So this is what Cedars suggests is a diagnostic approach for evaluation: MR of the brain with contrast, MR myelography, and epidural blood patch, because they feel like the majority of people have a good chance of getting better if you catch it early. The MR myelogram is a no needle, so we're not injecting gadolinium into the fecal sac. It's a heavily T2 weighted 3D volume, so there's not any flow artifact. We suppress fat signal so we don't get messed up with the leakage of CSF being fat. And you can see this extradural CSF, so that's a positive MRI. So this is not good enough for type 3 fistulas. We're never going to see those. It's not good enough to tell us exactly where the patient's leaking, but it gives us a place to target. This is most likely. Is it lateral? I should be doing decubitus. Is it ventral? I should be doing them prone. It helps guide the myelogram.
Could you clarify that? An MRI myelogram is just a T2 weighted spine image? Is that what you're talking about?
Correct,
Why do
correct.
they call it or is this something we have to order?
You have to order it.
So we have to specifically order an MRI myelogram.
Myelogram.
And it's a variation of a T2 image.
It's very similar to the sequence we do for skull data. A very heavy weighted T2 with fat sac.
Why do you call it a myelogram then if it's just?
Oh, yeah.
And
Sorry.
can you bill more for it or? Is it
I'm not getting into that today.
Yeah, sorry about that. Yeah, that's why this is a term widely used in literature. But yeah, I get your point. So there was a large meta-analysis in JAMA that said conservative treatment, which is just bed rest and hydration, 28%, first non-targeted patch, 64%, large patch, 77%, but I think that's kind of high. I think there's you know, there may be a lot of people getting these patches and doing better that are not getting to people that are writing articles. So like the people who are going to Cedars and UCSF, like dedicated centers, are probably people who've failed this, you know, failed blood patch. So let's talk about diagnostic workup and when blood patches have failed. If we see that there's epidural CSF ventrally on the MRI, we do prone dynamic CT myelogram or a digital subtraction myelogram. Those are the two best options if there's a fast flow looking for a spur. Now, can you just do a regular CT myelogram? Yes, you can. but it might equalize. If the flow's really fast, it might equalize and you might not know where it's coming from. So that's the downside, but
So when we suspect somebody, I mean, just practical, maybe you're coming to this later, but, we have a brain MRI that has pretty typical features, a clinical syndrome that's postural headaches and, debilitating headaches from being upright, et cetera. We're pretty convinced this person likely has intracranial hypotension, right? The dilemma for us as clinicians is what test do you order and in what sequence? And is there any way for us to kind of narrow that down and say, get this first? And our radiology department will tell you if there's any reason to proceed further.
the MRI myelogram has been shown to not be inferior to CT myelogram for just detecting a leak. Okay, so if we see a leak, then that helps guide, which would be the next test, which would be a prone myelogram. If it was ventral, if the leak was ventral, decubitus, if you saw no leak, or if you saw the leak out laterally, it would help dictate the way that Jennifer would want to do the myelogram.
So the MR myelogram is negative.
If it's negative, then what you're suspecting with a positive brain MRI and classic symptoms is that there's a CSF venous fistula. And so that's when you do the decubitus. You want to fill there. 85% of those are associated with meningeal diverticula. 85% of them are. So we want to see, we'll look on the MRI and we'll say, okay, which side has the most Tarloff cyst? Now that's like a normal finding, right? So you can't really know that that's a culprit, but in 85% of people who end up having fistulas, it's coming from a diverticulum. So we'll see, okay, maybe there's a bunch of them on the right-hand side. Let's do the right-hand side first. That's how
So I
you decide.
think the answer is you do an MRI first. You do the myelogram of the MRI. Then we do have always to do a CT myelogram. We do in the dynamic aspect of the myelogram, we actually see the injection. But if that doesn't work, you just see, and it has to be at another time. You have to do the decubitus myelogram, and there's a way to do the decubitus myelogram at the same procedure time to be able to do left and right. It's not the best, but in Duke, for example, they do it at separate times. They inject twice.
Right.
One on the left, and they come another day, they inject on the right, because it has to be, especially for the fistulas we haven't detected one here. It's very tough. I don't think our equipment that we're using.
Really hard.
That's sort of what I'm getting at. I've had 3 or 4 of these patients over the last couple of years, and I've tried to get a diagnosis, and I failed. And I'm pretty convinced that they have a fistula.
With a positive brain and positive MRI.
Yeah.
So we're really trying to do the decubitus. We're all learning. So we see the big ones, but the fistulas, it takes I guess an angiographic suite to be able to really detect that early washout, because it's otherwise with the equipment that we're using is going to be.
But I've also said the couple of MR myelograms I've seen, they're not nice scans. They're not like what we're seeing here in these.
No, we get. I don't think we need the myelogram. I think it's I feel very comfortable with the T2 that we can see the CSF around when it's out with our T2 stirs. I don't think we need the myelogram and the MRI. That's something that literature suggests, but not everybody's doing it. We could start making it happen. It's really a simple sequence, but you can see it in the structural imaging very well.
So it would be nice to have a protocol for it, though.
Yeah, I agree. That's part of the reasons why.
That's part of, part of this is about building a protocol, building a team. I want to show you, like, at Cedars, so they love digital subtractive myelogram, and they must have this a really well-oiled machine, because they're all done under general anesthesia. Mm-hmm. So with pressure augmentation if they need to. I mean, so this is that's the way that goes. Here's a small spur it's a type 1 leak. So we have epidural contrast coming out, shown by DSM. This is kind of interesting. So 90% of people with a type 1A leak will have a spur. So that's what we're looking for, is a ventral spur, but they can absorb over time. If you catch it early, it may be curable with lumbar blood patch, even if it's an osteophyte. So again, they're very strongly recommending blood patches. If it's late mature, greater than 3 to 6 months, you probably not even a targeted blood patch is likely to cure this fact surgery because the hole is basically well formed. DSM is often needed to confirm the leak site, and Cedars will just target the spur if they can't figure out where it's leaking from, which, trust me, happens. This is a type 1 leak. Look how tiny that little osteophyte is. It's almost microscopic. And then on the MRI, these little, what Dr. Dillon loves to call dog ears of CSF, that's a positive study. So a lot of times you think, well, it's not, it's because people might not know how to read it. You know, so,
and that's why we don't do the myelograph, because that's what we're looking for.
yeah, so we're always looking for this. He's looking for dog ears. So, and that can be very, very subtle, but it's quite apparent though. You don't need the 3D myelogram sequence to show that. That's true. So let's look at this case. All right, this patient had just a regular DSM myelogram. They didn't see anything leaking, but when they went to CT scan, they saw this epidural contrast. So this patient has a leak. There's no question about it, right? So they look at the CT carefully, looking for the little microspurs. They're at 3 different levels. Which one do you go get? And so this is a very difficult circumstance. And there have been some things developed where patients are actually, the contrast is injected, they're prone on the CT scanner, and the hips are elevated, and they scan caudal, cranial, caudal, cranial. Is that a lot of radiation? Yes, it is. Yes, it is. But in this case, we know there's a leak, so you feel, a little bit better about it, right? So here's the spur, and then you see that the contrast that's in the thecal sac exiting right at this level, spilling quickly laterally, and that's how they decided which level to go after. So I'll show you a couple of cases that I've seen. This is one of the golfers that I've seen who had a pop in his back many, many years ago. And we thought it would be just a regular, meningeal diverticular leak or something like that. But we saw this a huge leak in the ventral CSF space. And in fact, you can even see dephasing because there's so much turbulent flow in the CSF. And if you look up intracranially, you see this huge confluence of venous sinuses. You can see the dura deflected backwards here. On the axial images, this is a huge epidural collection compressing the cord posteriorly. He got gadolinium, and there's a vein, there's all like vessel enhancing, but there's no circumferential enhancement about this collection. Blood products are not layering posteriorly. So what this is, when you see following CSF signal with maybe some turbulent flow, this is a big, fast leak. So he had, interestingly, outside place, he had a regular CT myelogram. And you can see how fast the contrast equilibrates between the 2 areas because it's a fast flow leak. But sometimes, if you look to see where the contrast is the densest in the epidural space, it can give you a clue as to where that leak is. And that caused us to look closer at the bone and, oh, look, there's a little divot there. The contrast was running up quickly, spilling out into the space between C1 and 2. This has a name. This is called the fault C2 localizing sign. So a lot of people would operate here to begin with, right? Because they say, oh, it's the most contrast. That must be where the leak is. And that's wrong. That is just where the contrast tends to pull. Almost always the leak is lower. So in this case, the densest contrast was coming right from where there was a little spicula bone of the lamina. And this guy had a history a long time ago. He was playing rugby and they said, you broke your neck. He's like, no, I didn't. And he broke his neck. And now he formed a leak. He punctured the dura, formed a leak that has been persistent over a long period of time. This is one of Dr. Day's case of a patient who had an MRI at first for a year of orthostatic headaches. And the MRI was very positive. Pachymeningeal enhancement, everything I've shown you. And he had an MRI which didn't show the leak. So he went for a CT myelogram, which is a routine CT myelogram. And again, we got fortunate on this case because you can see this dense contrast coming from the spur, and he's only got one osteophyte, so that's helpful. And Dr. Day went in and fixed this guy with ACDF and patching of the dura. Do you want to say anything else?
Well, that little osteophyte is below the plane of the disc face, so I went inferiorly, and then I flicked the curette off, then a huge gust of CSF out. There's a big hole in the dura formed by the osteophyte. So we repaired it intradurally and enough to put some layer of Duragen on each side of it, and then I spinal drained for a while, and he did great. He
Yeah,
just immediately cured.
Immediately fixed. So
Yeah,
this guy, an epidural
okay.
blood patch would have been a waste of time. And this guy, right? So it's case by case in that respect. This is a case of Carl's. A patient had neck pain, but his real big complaint was ataxia, hearing loss, myelopathy, and dementia. He'd had a left C8 nerve root avulsion 40 years ago. And so I'm showing you this case to show you on the sagittal T2, what we're looking for is this thin line of dura with CSF in front of it. That is evidence of epidural CSF. When you look at the axial image, you see the epidural CSF being divided into the two compartments by the meningovertebral ligament. But we see something else that's kind of interesting. Notice the cords should be uniformly gray, right? But here it's higher in signal centrally and lower peripherally. So is this edema in this cord, and that's normal signal, or what? And fortunately, when you go and look at the highest images, the answer becomes very clear. This is a GRE image, and you can see just coating with hemosiderin of the brainstem and all the cerebellar folia. So this is what CNS siderosis looks like. Notice how the fast spin echo T2, because of the multiple 180-degree refocusing pulses that happen in fast spin echo, it's making it resistant to the dephasing from the hemosiderin that's occurring with the GRE. That's why we call it heme sequence. So this guy, Carl repaired this, and there's like basically a bloody stump. It's thought that a continuous like granulation tissue leaks heme products into the CNS. Carl repaired this, but the guy didn't get any better. And that doesn't really surprise me because once you've poisoned your cerebellum and nerve roots, the 8th cranial nerve, it doesn't really get any better. You know, you could just try to stop it before it happens, right? So the underlying etiology, dural tear is most common, cervical nerve root avulsion, but you could also have ependymomas, bleeding, or AVMs, supratentorially amyloid angiopathy. So I would talk quickly about CSF venous fistulas because you asked. We use MRI to localize probability, which site is most likely. And then the myelogram is performed in cubitus. This is from Cedars-Sinai, and you can see that once the diverticulum fills, then sometimes they see the vein field. This is very, very challenging, to say the least, because maybe the fistula is not filling. Just maybe the central venous pressure and CSF pressure is such that it's not filling. Who knows? Or maybe you're just wrong and it's a false, it's a false positive to begin with. So why does this happen? The theory is that there are arachnoid granulations all along the spine that drain CSF into veins. The theory is that either because of pre-existing idiopathic intracranial hypertension causing rupture or trauma, that these rupture and then form a direct fistulous communication. Roy was talking about the CT. You can either do DSM or CT myelogram, both in decubitus fashion. CT myelogram has been shown to have better sensitivity than DSM, which I guess probably not that surprising. 82% of these will come from a diverticulum. Lower thoracic spine is the most likely location. The majority of these will not have epidural contrast, SLEC negative. And CTM dynamic myelography is which one will show. Sometimes in this particular study, sometimes it was shown on CTM, not on myelography, not on DSM. So it's a variable situation of why are we not showing that? It's difficult. One of the recent advances, which is kind of cool to talk about, is a new CT scanner called photon counting CTs. You might have heard about these for vascular type work. The resolution of a regular CT scanner, high res, gets down to about 0.625. This high resolution mode is 0.2. less noise because they're able to use AI and binning of different KVPs of electrons to denoise the imaging. So we've got improved spatial resolution, it's faster, increased temporal resolution, and we're able to see small veins that we wouldn't have been able to see before. In many of these cases, we talk about respiratory augmentation, where the patient breathes through a straw to try to decrease central venous pressure during the injection. Injection of saline to augment pressure, multiple CT passes. I mean, you can see that this is a lot of radiation and a big deal to do these workups. So you can see that we want to look for indirect signs to see in these patients that we suspect may have a fistula. Is there an indirect sign that I'm correct? And one of the things is renal excretion. When you normally do a myelogram, you don't normally get excretion from the kidneys. So if you look at the kidneys after your myelogram, even if you miss the leak, you better go back and look again, right? Or, because they're probably a leak. So this can help us say, okay, we need to really look close at this patient. It is more likely for a fistula, a venous fistula, to put contrast in the kidneys than a large dural tear, although both can do it. And then my favorite article of the year, and when you first look at this article by Dr. Shivink, you go, okay, big deal. This is a patient who has an active fistula and we don't see CSF around the optic nerves. And now he repairs it surgically and the CSF returns. Well, so what? It's just, that's not surprising. But look at his study group. These are patients with orthostatic headaches and normal findings, normal brain MRI, normal spine MRI. Which ones do we want to push on, right? So because this is tough. So 50% of his patients had fistulas if the cutoff was below, and I gave you the numbers that he found on the Yoden's analysis, and only 2% fistulas when the values were greater. So he had 92, 93 patients. He found fistulas in about 16% of patients, normal brain, normal spine MRI. So remember I told you Cedars uses exclusively DSM under general anesthesia. So how do you get 92 people to sign up for that, right? So these people were severely disabled. The average length of time of headaches was 5 years. How many studies do you think they had trying to figure this out? So these are not people who just had occasional headache or just a little brain fog. These were people who were severely disabled. And I think one of the things when you look at literature, you have to say, what was that? You've got to really look at it. What was your population? Is that the same as mine? Because you're not going to expect the same results if that's not right. So anyway, interesting. And Jennifer likes, she likes the 2D, the 3D T2 weighted brain MRIs where she likes to look for this finding as well. So let's talk about treatment options quickly. That's going to be a whole hour, so I'm not going to do much on this. Blood patch, non-targeted versus targeted, fibrin glue, transvenous embolization, and finally the gold standard is surgery. Again, targeted better than non-targeted, large volume better than small volume. Transvenous embolization with Onyx is something that we're just now starting to get into that was pioneered at Utah. So post-treatment intracranial hypertension, in about 25% of patients at Cedars, so they will get a rebound hypertension. Some studies have said it's more common in patients with epidural collections, type 1 and type 2. The headaches are different. They get worse when you lay down, right? And then when they're more frontal, increased opening pressure, bilateral papilledema. I remember reading a case that Cedars reported that said the patient was worse. He was like, my headaches are way worse now. And it can respond to acetazolamide. So you might wonder, in these patients with the layered cranial hyperostosis, are they more likely to have rebound headaches? It'd be interesting to see. Nobody knows. So in summary, SIH is a syndrome of headaches, usually at some point orthostatic, although that history can go away, audiovestibular symptoms, and a myriad of other nonspecific findings related to CSF hypovolemia. The CSF loss is caused by a leak in the spine. The Bern score can assist us with saying which people are going to be high probability. A routine blood patch may be curative. And whether there is epidural, contrast, or CSF detected or not helps us determine the best myelogram technique. And then finally, always consider all the imaging findings and clinical history before arriving at a diagnosis and get the prior imaging on these PREs. That's a real pitfall. And finally, a normal brain MRI does not exclude SIH. And I've got just about 10 minutes. I'm going to show you Richard's case. So Richard sees like a quadrillion cervical spines over the course of his career. And he says, what's that? That doesn't look normal. I don't usually see that. And when we look at axial images, we see that this is the epidural space is expanded, and this looks like an enlarged vein to me. So I'm like, oh, wow. So you've got on a cervical spine in a patient who just has right arm pain. We have engorged epidural veins. So what do we do? So I don't know if I regret this. I kind of regret this. So let's get a brain MRI. And oh boy, right? So she had a high Bern score. I think she had like a Bern score of 7. And you see the classic dural enhancement. Her suprasellar cisterne's gone. Her pituitary is prominent. This measurement's normal. That's decreased. There were just no subdurals. So she did have venous engorgement. So she's got a Bern score of 7, but she's got no symptoms referable to SIH at all. So I called up Dr. Shiva and go, what do you do? What do you do? You know, because this is a pathway to a lot of testing. And what do you follow if you do all this stuff? What do you follow? Did she get better? Well, she never was bad. So he said he has quite a few patients, not quite a few, but he said he has a few patients like this that were completely asymptomatic, clear-cut leaks. He said he would non-invasively image the spine, and he would do a blood patch. And if the patient's right arm pain got better, he would consider it a win. So she got a blood patch, and obviously her headaches, because she didn't have any, didn't get any better, but her brain MRI became normal. Her brain MRI was read out the next time as normal. And she did have a non-invasive MRI of her spine, and she had 2 large diverticula on the thoracic spine, almost certainly the culprits for the leak. But since her brain got better with the MRI, so now we're just going to probably follow her with sequential MRIs since there weren't any headache symptoms, and we're going to throw in a GRE sequence to be sure she doesn't develop any evidence of siderosis, although she's unlikely to because she's not SLEC positive type 1 or 2 leaks, right? So anyway, it was kind of an interesting case.
What's the data on how high up the lumbar blood patch goes?
Oh,
So you say the thoracic leak,
I've seen
and you did a
some
lumbar blood
nuclear
patch.
medicine studies that tag the red blood cells, and they go all the way up, you know.
Right. And when we do the blood patches, it's really not, that's why the focused ones could be better, but we do not do it to go at the site to close the leak. What you're doing is you're just compressing the sac to increase the pressure and relieve. So
Turning the tide.
but yeah, it can go up all the way. So the epidural space doesn't have much resistance. So if the blood can go up and down as much as.
I was just curious. I mean, sure, obviously the mechanism being what it is doesn't necessarily mean that you have to get up to the thoracic spine.
Correct. Yeah, you don't actually have to deliver it to the area. There is some evidence that it in some controlled stuff, not control. I don't consider it control to say that you did a non-targeted because you couldn't find the leak and you did targeted when you could. That's not randomization, but there is some evidence that targeted is better, but it's not. There's not a large randomized controlled trial on that at all. But certainly it's easier to do a non-targeted, it's safer to do a non-targeted, and so why not? Why would you try? Because there's very little downside in these people.
So we put contrast in all of our blood patches to see where the contrast goes, and it goes pretty high everywhere. It just distributes very fast throughout the spinal canal. There's no resistance, right? That epidural.
Volume do you put in?
Depends. We do it until the patient cannot tolerate the pressure in the pelvis.
So you push, and you say when your head starts to hurt, and
it's mostly the legs and the pelvis starts hurting a lot, and that's where we stop. That's why, and you don't want to do nerve damage or nothing. That's where we do it awake always.
Yeah, very smart. Yeah. So like 20 cc's is like a typical considered large patch, but But when you think about, there was a great article by a guy named Levine from NYU, a neurologist, who talked about the pathophysiology of the lumbar puncture headache. And he talks about how the epidural space in young people and the very old has more resistance than in middle age. And I don't know if that's true or not, but he was citing some study where they had epidural catheter pressure measurements. So he theorized that that's why we don't see this as much, is because of differences in the resistance in the epidural space in children and the very old. I don't know if that's true or not, but it does make a really good argument that when you create an anomalous connection between the subarachnoid space and the epidural space in the lumbar spine, okay, and you decrease filling pressure because you begin to lose CSF, the point of hydrostatic indifference, which is usually between the lower cervical spine and upper, like down to T5, let's like C7 to T5, where the pressure is neither negative nor positive when you're standing upright. So, intracranial pressure upright is slightly negative. When you increase compliance because you've formed this connection that you shouldn't have between your subarachnoid space and your epidural space, the distal lumbar sac becomes more compliant. And therefore that point of indifference moves caudally, and there's increased negative pressure in the head. They use that as an explanation for why CSF leaks out the nose don't cause this type of orthostatic headaches and don't cause the cranial findings that I'm showing you. It was kind of interesting article anyway.
This is such a fascinating problem. And historically, what's particularly shocking is it's relatively high incidence, relatively high prevalence, absolutely pathognomonic stigmata at its extreme. And I never knew about this as a resident. I mean, it's just unbelievable that this entity has existed throughout time.
It is, right?
Well, it shows what you can see. When you can see something, you can diagnose it. We didn't have the tools when you were, or certainly not when I had to see the imaging. We had myelography with pantopeg, and
Right.
pantopeg would not fit into those.
But now if you follow it further, now we talk about once we see it, because we see it, then the workup, which is what all of this discussion becomes. What I would suggest is if there's an argument to have a center here, which I think is a fantastic idea, that it's being underdiagnosed. Mm-hmm. And the target probably isn't in this audience because everyone now is kind of attuned to it. But I would say neurology, I would say ENT, and even primary care physicians, because these are people who can just have dizziness or tinnitus or such vague complaints. They order a non-contrast MRI and they say you're fine.
Well, I would notice in response to your comment, Richard, that our spine faculty is not here. They've gone to do cases, I think, I imagine.
They're working.
And this
They're
is
producing CSF leaks as well.
well. But, on the other hand, the concept of a center is, I think, a spectacular one, because this could help so many people. So many people. We're talking about getting a center for trigeminal neuralgia, for hemifacial spasm. We really ought to have this at our place. And we have a specialized neuroimaging center and spinal effort in our department to have. It's a great idea that we should do. Would you write that up for us and we'll submit it to Jacques and have it done?
ChatGPT will take care of that quickly.
Okay.
Very good.
Great job. Great job.